If this patient starts on an ibrutinib-based regimen, I would expect that they should derive at least a few years of benefit from it. However, we don't think that ibrutinib is going to be a curative option for patients like this, and so eventually they are likely to progress. At that point, we have a couple of different options we can consider, and we have some data sets to guide us in this respect. One of them is some retrospective data that have recently been assembled by Anthony Mato and colleagues, suggesting that a drug venetoclax, which targets BCL2, completely different mechanism from ibrutinib, may be effective for this group, and at least in this retrospective series, the patients tended to have more durable responses than switching to other drugs like idelalisib, which is hitting a similar pathway as ibrutinib. We now also have some prospective data to guide us from a phase 2 study that was conducted by Jones and colleagues, treating patients who are progressing on ibrutinib with venetoclax, and about 2/3 of patients achieved response with good durability in that group. So typically for a patient progressing on ibrutinib now, if they're a candidate for venetoclax, that would usually be the drug I would turn to next, unless they had certain comorbidities. For example, renal dysfunction can make it challenging to start venetoclax due to a risk of tumor lysis syndrome. And in that type of patient, I think idelalisib, potentially with rituximab, is a good option for that patient. In terms of how we're sequencing the novel agents now in CLL, we've been mainly using chemoimmunotherapy as frontline treatment in most cases, and I would say in general what I've seen is that ibrutinib has been used most commonly as the first agent in time of relapse. Now this is all evolving as ibrutinib is moving up into the frontline treatment regimens for more and more patients, and then the question becomes, what do you use after that? And at this point it seems like venetoclax is becoming the next drug that most people are reaching for. I think what's going to be interesting in the field is that venetoclax is also moving up into the upfront setting. For example, an ongoing study called CLL14 is randomizing patients to venetoclax with obinutuzumab as a frontline regimen versus chlorambucil and obinutuzumab. And if that study is positive, then that's going to have major implications in terms of the sequencing of these different drugs. And then furthermore, if regimens that combine all three of the major antibody regimens, the obinutuzumab, the ibrutinib, and the venetoclax, if those are all given in the frontline setting, I think it's a very exciting opportunity to get very nice responses, but the question becomes, what do you treat those patients with if and when they relapse? And I think that's a major unanswered question for the field right now.